So I'm going to kick it off and talk about sex matters, and this will be insights from the WISE, which stands for Women's Ischemia Syndrome Evaluation and beyond. This is my disclosures, and I am actually not supported by the company that is supporting the evening tonight, so no conflict of interest there. So I do want to start out because a lot of the research that I will show actually was earmarked by Dr. Bernadine Healy. So when she became director of the National Institutes of Health and she commissioned the Women's Health Initiative, because we knew so little about that subpopulation of 51%, that we really needed to know more about heart disease. We needed to know more about the leading healthcare threats to women, and that was the Women's Health Initiative. But there were small monies set aside for targeted, specific studies, and the Women's Ischemia Syndrome Evaluation was one of those. And they didn't give us the money. We did have to compete for it. But it really is Dr. Bernadine Healy's legacy. You are aware that she passed from a brain tumor 2 summers ago, prematurely. And we don't talk enough about her and her legacy. And we actually have started, and next year's ACC, there will be a Dr. Bernadine Healy Leadership Award. And it will be open to women and men, so be thinking about who you might want to nominate for that. But she's left an incredibly important legacy. Bernadine opined in 1991 in an editorial written in the New England Journal of Medicine that she thought that the reason we were seeing an epidemic of heart disease in women, where more women were now dying than men annually, she opined that she thought this was the Yentl syndrome, and it wasn't coincidence because 1991 was the year that the Barbra Streisand movie came out. And that is the picture of Barbra Streisand dressed up like a man. And if you remember the Yentl story, or if you read the book, it's the 19th century heroine of the short story. She had to disguise herself as a man to attend school and study the Talmud. So at that time in Eastern Europe, to become literate, you had to be a man. And so Barbra Streisand told this story and acted in it. Being different from men meant being a second-class citizen and less than equal for most of recording time and throughout most of the world. These are Bernadine's words. It may therefore be sad but not surprising that women have all too often been treated less than equally in social relations, political endeavors, business, education, research, and health care. And this was what Bernadine was talking about. So in 1984, women became the majority of heart disease deaths in the U.S. The Yentl and the Yentl syndrome was 1991, so Bernadine was calling attention to it. And it wasn't until the late 1990s that the WISE was commissioned. The American Heart Association began their Wear Red and Go Red activities. So it really took 12 years to recognize and take action. And I sometimes reflect, had this been an infectious disease epidemic, the CDC would have acted much, much more quickly. So let's look at what we consider some of the disparities in ischemic heart disease. And these are facts. 35,000 patients with ST-EMI, about half are women. So many of these data sets are quite representative. Women have increased rates of diabetes, hypertension. Although they've had a lower history of prior events, they're less likely to be treated with aspirin, heparin, or other medications that are life-saving, less likely to be revascularized, less likely to be discharged on those 4 magic pills, and these are the pills in the guidelines that save lives, and more likely to be dead, have recurrent MIs or heart failure. And so these are evident, very consistent, continue. We just finished with the RAND Corporation, California insured population. We still have these 10% gaps. So some things have not changed. So what are potential explanations for these disparities in treatment? Number one is blame the victim. Women do not seek health care for symptoms or delay seeking attention. How about ageism? Women are older on average. Older patients are less aggressively treated, for better or worse. How about sexism, which might be appropriate, which would be considered medical judgment? For example, sexism in medical judgment: a man presents to you with breast pain, a woman presents to you with breast pain. Guess who will get the mammogram? Well, that's sexism. But that's medically appropriate, isn't it? Because breast cancer is very rare in men. Okay, so sexism for this disease, women, it would be if we believe that women are less likely to have or die from CAD, then they would be less likely to be treated or evaluated. And then finally, biological sex differences in ischemic heart disease, something that we'll talk a lot about tonight. Women are more often presenting with female pattern disease, and this is not recognized compared to male pattern disease. So this Yentl syndrome will pop up again and again. All right, let's talk about data that supports any of these hypotheses. Here's data from the New England Research Institute. It was a very well-prospective, well-done study this is not just observational data with post-hoc analyses. They said, in response to chest discomfort and shortness of breath, how do women and men do, and how do ethnic minorities, here African Americans, do? And this has to do with blame the victim. Do women not come in? Do African Americans not come in? Do they come in late? And if you see a difference between those bars, tell me. There were no differences. So women and men responding to chest pain and shortness of breath came in with equal prevalence and equal rapidity. And yet what you can see in terms of secondary care, in terms of the emergency room response to chest pain and shortness of breath, women and ethnic minorities, African Americans, received significantly less care. So it doesn't look like we can blame the victim. All right, what about ageism? Women are older, maybe older women are less aggressively treated, maybe that's appropriately. This is Viola Vaccarino's work. Some of you have seen this before if you've seen me lecture. It's a compelling story published in the New England Journal, and it has not changed. The biggest gap is in young women and young middle-aged women. We're not talking about 18-year-olds, but we're talking about women between the ages of 45 and 65. And the biggest gap was 50-year-old women, so middle-aged women. All right, so it's not ageism, at least the majority of the gap. What about sexism? Is it true that women are less likely to have or die from cardiovascular disease? Are these death certificates wrong? Do women have a disease that's completely different? So here's the paradox, and this is really what got us started in the WISE. Looking, and you can look at any cath registry data. You can look at the NCDR, you can look at European data, you can look at Canadian data, which we've done now with my Canadian fellow. It's very consistent. So if you take an acute coronary syndrome population or an STEMI population or a non-STEMI, pick a definition, you will see this pretty regularly. And here's what we see. Women are more likely to have preserved ejection fraction. They are less likely to have obstructive coronary disease. In fact, 1 out of 4 women will have no obstructive coronary disease, despite meeting criteria for an ACS and not infrequently positive enzymes STEMI. They're less likely to have extensive and severe what we would call revascularizable disease. And again, remember, women have less bypass. So maybe that's right. I mean, you're not going to bypass something that is not there, right? And yet they were just as equally likely to die. And if you disease severity adjust this, they're more likely to die if you adjust for their angiographic severity. So it might be sexism because we're not recognizing a female pattern of disease. So that is our last hypothesis. Let's see if we can defend this. So this, again, if you've heard me lecture before, this is a systematic review of randomized controlled trials where patients went urgently up to the cath lab, and we counted up the prevalence of normal and non-obstructive coronary. These all had core labs, so this was not just somebody's idea that the arteries were open. And you can see very consistently that anywhere from 10 to 30% of women have acute coronary syndromes, including STEMIs, with open arteries, and that is about 10% in men. So this idea that obstructive coronary artery disease causes acute coronary syndromes is very true in men, but it's not true in up to a third of women. And a third of a very large number is a lot of people, right? We have 500,000 deaths annually. So a third of that, they're somehow dying with open arteries. So it really shakes our paradigm. It really asks our question, what are we doing? So we've spent now almost 18 years with the Women's Ischemia Syndrome Evaluation describing what we call female ischemic heart disease, female pattern. I chatted with a colleague earlier, and she said, well, why didn't you have male controls in the Ys? And I said, well, actually, we tried to get NHLBI to fund some male controls, and they said no. But what we really wanted to do was exclusively study women, because until you really study women, we're always being compared to men. And that's probably, given the epidemic, probably not the best approach. So here's what we described. Microvascular coronary disease, and these patients typically have signs and symptoms. So there's their sign, angina. There's symptoms of angina. The signs are an abnormal stress test. Open arteries in panel B. Abnormal diminished coronary flow reserve, as well as elevated filling pressures. And this is, of course, in the absence of cardiomyopathy. There's no valvular disease, et cetera. Extensive, often severe atherosclerosis by IVUS. And with our colleague, Dr. Leslie Shaw, using the NCDR database, we've estimated that there are as many as 3 million women in the US. There may be as many as 1 million men. That this places for women, this is a larger problem than breast cancer. So we have looked at this diminished coronary flow reserve. This is why we call it microvascular coronary disease or dysfunction. It is a good prognostic predictor. It is, as you know, currently measured invasively. So this is with Doppler flow catheters in response to adenosine. So would this then explain delays in symptom recognition and treatment? If you don't look like you have obstructive coronary disease, and that's sort of the game, right? That's you have CAD, then treatment is delivered. So if you don't have that, then treatment doesn't get delivered. Would this also explain misdiagnosis? I have women, our new senator from Massachusetts, her mother passed after having gallbladder surgery. And just as she was being discharged, she told the daughter and the husband that she was having that pain again, the pain that they had taken the gallbladder out. And she had sudden death in the hospital, didn't get to go home. And at postmortem, she had a massive MI. So she'd been having angina, and they took her gallbladder out. So, I mean, it explains a lower use of angiography, revascularization, aspirin, beta blockers, statin, angiotensin-converting enzyme inhibitors. Again, these are the 4 magic pills that you hope your physician will prescribe. Less counseling and risk factor control, fewer refuelers to cardiac rehab, lower adherence to proven guidelines. And we know this all counts. If you have cardiovascular disease and you don't get these opportunities, this will result in increased mortality. So once again, just to sort of sell this message one more time, and to send you back to clinic thinking about something that might actually hopefully be useful. We have several data sets now that have been published internationally, and I was asked to write an editorial to the European Heart Journal. And these were 2 registries that basically, supported and confirmed and extended our WISE observations. So here's how it goes. Women and men come into the emergency room with angina or acute coronary syndrome. More men are recognized. So you can see on the upper panel, there are more men that are recognized as having acute coronary syndrome. There's a few more women having their gallbladders interrogated. There's coronary angiography, and you can see that there's two patterns. The pattern on the left, we see, right? Obstructive CAD, we understand that. Microvascular, we don't get that. We don't get to see it with routine testing. When you have obstructive CAD, when you look like a man, as Barbra Streisand does here, you get treated. When you look like a woman, as she does on the right-hand picture with her husband, you are much less likely to get life-saving therapy. And this, of course, then results, and you can see that there is a surplus of female deaths. And you can do the math. You could see this in both of these registry studies. All right, so what's the answer? Well, number one, what's the problem? So is the problem lack of patient response to symptoms? I would say no. The data suggests no. Provider sexism? No. Is it ageism? No. Does it look like a lack of knowledge and a recognition of female pattern ischemic heart disease, resulting in a failure to use guidelines therapy? That's what I would say we have evidence to support. So how to get results? Rename it ischemic heart disease. And you will see in the new guidelines, there's stable and not stable ischemic heart disease. So they're now asking you to call it IHD. Don't call it CAD anymore. And every time a fellow says CAD, I say, nope, that's not the name anymore. And it's like Pavlov's dog, right? As soon as you say CAD, they start getting their stent catheters out, right? So you got to rename it, and you got to correct them. Okay, and then use a simplified approach to ischemic heart disease management that improves adherence and ABC format, which you've seen before. Here's your ABCs, and the ones in yellow are the ones that post-ACS save lives. So these are the ones that you absolutely do not want to forget, and you need to make sure that patients are discharged on these when they have an ACS. All right, so what about women and men with a female pattern ischemic heart disease? People say this all the time, wait. The guidelines aren't relevant to your population, Noel. And no, remember, the acute coronary syndrome angina guidelines are not cath-based. They don't say first do a cath. They say acute coronary syndrome, treat. Angina, treat. So read the guidelines. Abundant evidence exists documenting the life-saving risk reduction of these 4 magic pills. And this is the power of the prescription pen to actually save lives. And it's okay that they don't need stents, and it's okay that they don't need bypass. Here are clinical practice guidelines. So since we've been doing this work, we have altered 2. More work to come. But here's what's happening with guidelines therapy. You know this. This is Greg Fonarow. If you actually use guidelines, you will increasingly get the right patients on the right drugs. And this is not our work, but I was incredibly gratified to see it come out. This is a historical temporal trend. So there is an initial cohort. So following guideline implementation for this ACS, the mortality for women improves significantly, and the sex gap narrows. And look at the top 2 lines. Those are the male lines. So post guidelines, we didn't save any more male lives. And why was that? Because they were already getting treated. So the guidelines were already being used. Here's what's left. So the persistent gap suggests that more work is needed to understand either sex-specific pathophysiology or to conclude that women should not live as long as men. So, right, okay. I rest my case. So we looked at that first alarming time trend when Bernadine Healy wrote her Yentl editorial. So here's what's happened in the following years with our WISE and other campaigns. So we have bent the curve. Now this is true, possibly related, right? We've done a lot of work. We've shaped guidelines. We've worked on guidelines campaigns. We've had, educational programs such as this. But we are pretty gratified. The 3 blue arrows are the 3 American Heart Association surveys that have demonstrated increased awareness at a community level that heart disease is the leading killer of women. Now, are we happy? Are we happy that we have twice as many female deaths as men? No, of course not. And we're doing a good job with the men. All right, so here we go. In conclusion, women face a higher mortality from ischemic heart disease, we believe due to their relatively higher prevalence of female pattern ischemic heart disease. Application of guidelines therapy is improving outcomes for women, so we really need to stay on this guidelines campaign. Yes, of course, we need improved diagnostics. We're going to talk about that tonight. But at a minimum, when we get patients that clearly have ischemic heart disease, they should be treated regardless of what their cath shows. Ongoing work is evaluating further mechanisms as well as interventions directed at these sex differences. I'm always happy to hear questions, comments, and referrals. We continue to enroll for WISE and RWISE. So we're always happy to see your patients and send them back.